That's helpful. So our main objective with doing this project was really not only to improve outcomes in our young adults with type 1 diabetes, but also bridge equity when it comes to technology uptake in our patient population. So as part of the type 1 diabetes QI collaborative, we joined the Equity Pump and CGM project last year. And we want to look at our CGM and pump prescription rates in our young adult patients as part of the SEED program. The study period was January 2019 to December 2021, so 3 years. And our main objective was to see whether we were making any difference, whether our young adult program was really improving technology prescriptions and uptake over time in an equitable manner. I think it's not forwarding slides again. So our methods, as I mentioned, once we joined the QI collaborative and joined the Equity Pump and CGM project, we did a mid-stage evaluation of our clinical interventions, going back from January 2019 to present. And we had an IT team at our center, which we collaborated with for data mapping. So our inclusion criteria is we included the patients in SEED, the type 1 diabetes patients defined by ICD-10 codes, aged between 18 and 35 years. And patients had to have at least one visit, either telemedicine or in person with an endocrine SEED provider in the past 12 months. We looked at our monthly CGM and pump prescription data. So the way we calculated that was the numerator being the number of people prescribed the device in the reporting month, and the denominator being the total number of SEED type 1 diabetes patients seen by endocrine in that month. So coming to our results, overall, we saw 253 young adults over the 3-year study period from Jan 2019 to December 2021. The average age was 23 years, 53% were female. And looking at the race ethnicity breakdown, this is pretty similar to the demographic that we see in the Bronx, where 55% of the patients were Hispanic, 22% of the patients were non-Hispanic Black. Very few, 10% actually, were white, and 13% of unknown race and ethnicity. So looking at our young adult CGM prescription rates, so overall, we were really happy to see over the 3-year study period with the SEED program and with all the interventions we were doing with the type 1 diabetes QI collaborative and SEED, the numbers improved from 31% to 69%. This is looking at CGM prescription rates overall, and those were significant results. We were also really happy to see that there were equal improvements in Hispanic and non-Hispanic Black, from 13 to 71% in Hispanic in the green line, with a positive trend throughout the study period, and 33 to 55% in non-Hispanic Black in the yellow trend line. In the next slide, I also wanted to show you the data for our white population. It's very variable, and this is, we think, is one because the number of patients in our white population were very few in our SEED cohort. Also, early on, a lot of the CGM prescription rates were actually on paper, and we don't think we were capturing all the data on the EMR, and more progressively, we started to be able to capture it a little more. But the white data line, the trend line tends to be very variable. But also with a positive improvement over the last 3 years. Looking at our pump prescription rates, I mean, not as dramatic as an improvement as compared to CGM, but definitely there was an improvement over 3 years. So overall, from 6.3% to 31%, which we can see in the red trend line. And again, equal improvements that we can see in Hispanic and non-Hispanic Black, to 39% in Hispanic and 37% in non-Hispanic Black. Looking at the white population again, very variable, and even more so for pumps. A lot of our prescriptions were going actually through paper prescriptions in the first 1 or 2 years, and only more recently, now that we've started to prescribe more using EMR, we're able to capture the data, but very variable when you look at our white trend line. So finally, to conclude, looking at our CGM and pump prescription rates in our SEED cohort over 3 years, we do believe that a tailored program is for these young adults transitioning from pediatric care with type 1 diabetes that focuses strongly on equity can improve technology prescriptions and eventually uptake over time. Future studies definitely are needed to examine the longer term impacts on care engagement measures, patient-reported outcomes, A1C, diabetes self-management report, etc. And as a participating site in the Type 1 Diabetes QI Collaborative, we hope to continue working on these interventions to improve our technology prescriptions, focus not only on improving prescriptions, but definitely also being able to capture and translate to patient use. And finally, share our learnings with the collaborative. So I want to say a big thank you to this amazing institution, and a special thank you to Ori and Osagi actually for really helping us over the past 2 years being part of this Equity Pump and CGM project. I wanted to say thank you to Shivani, who's been a wonderful mentor and support, and our chief, Dr. Crandall, and all our providers, patients, and nursing staff in our institute and the SEED program. Thank you so much.
You know, we did a project increase prescription rate, you know, what do you have a single intervention of all the things you tried that was like the most effective?
If you could repeat the question for those.
Right. So the question was if we had one one most effective intervention or to improve technology uptake over time. So we did multiple things over the course of the 3 years. I think personally that maybe the most effective was actually being able to train our nursing staff and doing device trials in the clinic. This way, when patients came to clinic and they were asking us, what is a CGM? We could put it at the point of contact and actually have our nursing staff train these patients at the point of care, have them try on the device for 2 weeks. And almost all the patients that I think I tried personally this with came back 2 weeks later asking for a device. So I think that personally, I think was the most effective intervention. Thanks.
I'd like to introduce our next set of speakers. So we'll have Blake Adams and Grace Nelson, correct? Or yes, coming to us from University of Tennessee and Le Children's.
All right, we're tag teaming it today, but I'm Grace Nelson and this is Blake Adams, and we're talking about increasing accessibility to CGM in an equitable fashion. Yeah. So, you know, our mission at Le Bonheur, as it is for all of us, is to partner with families and really aid them in finding the best way to help manage their diabetes. And we all know how technology can be helpful, but of course, for that to be helpful, they have to be able to use it and keep using it. There's multiple studies showing that. In our population in Memphis, Tennessee, we have all close to 50-50 Black and white patients that are type 1 diabetes, not quite, but close. But even with that, our disparity in the CGM use was quite large. And so our goal was to increase CGM use specifically in our Black patients from about 35% to at least 45% by June of 2022, and then decrease the difference to by 10%. The difference between them at the starting was about 35% to 40% between white and Black patients. We'll just skip past that to her. I'm sorry, didn't realize that was, there we go. So going through our key driver diagram, the first one being equity and social determinants of health. We were able to participate in a health equity. Oh, no one can see it. The health disparities. That's not the word. Implicit bias training. Thank you. Sorry, I'm used to seeing that. The implicit bias training in our whole clinic. Again, training, not necessarily the best QI thing, but it helped to open our clinic's eyes. And then the other thing we did was presenting our data to our clinic, really showing that bias that we had for both pump and CGM use to help everyone understand where we were starting from. We do have a social worker in the clinic, and we really started to try to target issues with SDOH to see what we could do to help our Black patients and to get them more of them on CGM. And then we were able to utilize a community outreach staff that was helping families for a variety of things, not in the clinic, but they would meet families in the clinic and then actually help them at their homes. And as part of sort of a bigger, different project, but we were sort of able to tag on to that to some degree to help with uptake of CGM use, especially with some of the more difficult steps. Education and training, again, as I said, I don't know that this is the best thing for QI, but some of the things that were sort of forced is, really updating our CGM folders with education that was necessary, but not too much, right? Like the frequently asked questions, the issues they're really having, but not so much information that people just throw it away. And so this has been a continual update process through this whole thing to try to really hone in on what we need in there. We also had staff attend Dexcom training so that our staff members were more versed in Dexcom, we're no longer scared of it. We're able to do little troubleshooting with patients and things like that, even placing Dexcoms on patients in the clinic at times. And then we partnered with Dexcom. We weren't able to get in-person training from them, but we at least got virtual training, which I think is a little better than the videos. Policy, insurance, and access, I think I can almost lump together. That still becomes our biggest issue, is that we see a lot of different insurances in Tennessee and Memphis. We're in the corner, so we get Arkansas, Mississippi, and Tennessee. Everyone has different policies. So what we actually did is we had a CGM champion. We had one nurse really take over the whole process and be able to follow it from start to finish and keep track of which insurances require what things. I know you said, couldn't you just look it up? But really it's more than that, right? So she was able to target which patients did we actually need logs from, which could we just submit. And then she even went as far as to follow up, calling these patients after clinic, asking them for their logs, calling them before their next clinic, asking them for logs again, doing her absolute best to get that stuff we needed. We're continuing to try to write letters and petition these insurance companies, but also doing everything we can from our side. The last thing is the communication and shared decision-making. So really making sure that family had all the right contact information in that CGM folder for contacting Dexcom, contacting their DME company, and contacting our clinic, and sort of when to do what. And then we were able to, we used Alabama's My Diabetes Journey to really try to keep that conversation going in the clinic, so that patients could sort of bring it up if the provider forgot to. Did this for our pump project too, but to help so that they could really be part of that conversation.
So this kind of is looking at our process map, and we've kind of gone over most of it already, but specifically looking at like the pain points, what was not going well, what we wanted to try to improve and work on. So we didn't have a consistent way to introduce it just to patients in general. There was no like day one education where we talked about technology, CGM specifically. We also just confusion on how the providers were going to order it, how they were going to send the prescription versus DME versus pharmacy, just lack of follow-up once we did send the prescription. No formal process of like collecting logs like Grace talked about, filling out DME paperwork, keeping the documentation in the EMR pretty consistent. We didn't have any way to go about that. And then we did run into the fact that the families were uncomfortable just looking at videos. They wanted to talk to somebody. They wanted somebody to walk them through it. We didn't necessarily have staff to do that, but we needed an answer to that. I think your question earlier about like, what was that one thing you feel like really helped your project specifically? And we do think it's the CGM champion role. We had a nurse that volunteered and has been super passionate about the project and just kind of run with it. And it's been fantastic for our clinic specifically. She can help with inpatient CGM start, so she can walk over to the hospital and start, especially our 5 and under kids, start them on CGM inpatient. She's our insurance liaison. She's partnered with DME companies, has their email addresses, is able to communicate back and forth if we're running into issues. She's a point person for clinic staff. Like if you have questions, you know to go to Jamie. She's just the person to talk to. Communicating with families specifically through like the portal, sending them messages, kind of keeping them updated on the process so everyone feels like they're in the loop. I could go on and on because I do feel like she's been vital in making this successful. The education folder that we hand every patient when they start on CGM, we just keep it updated, and Jamie's good about making sure that we have the most up-to-date information in that. And then also just creating standardized language in the EMR so you can look at a patient's chart and know what step they are in the process, which is helpful. So our results, our baseline data in January 2021 showed that 35% of our non-Hispanic Black patients use the CGM regularly. And as of July 2022, we now have 55% of our non-Hispanic Black patients using CGM. So not only did we reach our goal of 10, we doubled it, we got 20%. Our overall clinic CGM use also increased from 50 to 70. So we're happy with the changes that we made in that same time frame.
And here's just kind of a graph to look at it. And you can see over time, our numbers have increased. The one thing I want to point out is we didn't decrease our disparity as much as we would have liked. And so that's definitely something we want to move forward and try to continue to work on. The oranges are non-Hispanic Black patients, and the blue is our non-Hispanic white patients. And then just in conclusion, kind of looking forward to like what we can still do. We want to reduce that difference in the disparity between the Black and white populations and continue working towards our process. And then also just to reiterate, we feel like the most useful change was definitely our CGM champion, able to track the patients, and just having that point person to go to has been instrumental. Here are our references and any questions. And also thank you for letting us start.
Yeah, so with the CGM champion, was this a new role created? for
Yes.
This project, it wasn't somebody that shifted over.
Just repeat the question.
Oh, yeah.
Oh, so was it a new role that was created for the project? Yes and no. It was a clinic nurse that took on the role of managing the CGM because we realized we were doubling up on work constantly with starting processes and then stopping and like not knowing what was happening. And so she took it over. And it's part of her regular nursing duties. And
Will this continue to be?
Mhm. Oh yeah, there's not like extra funding for this project. This is just part of the clinic now. Yeah. At one given time, oh, that's a really good question. I mean, so how many patients is this person following up at one given time? She has anywhere, I think she told me anywhere from like 5 to 20 open charts at once. Initially, it was like in like a literal folder, but then we did get her like an actual Cerner inbox that she had messages that she was keeping track of. That was a fight too, but it was like a literal folder she would carry around. You know, I think a lot of it comes back to which insurance a lot of these patients are on still. We have a lot of the Medicaids have gotten better, but we have one of the Arkansas Medicaids is really bad and just got worse because now they've refused all pumps too. So that's fun. And one of our 10 cares is really bad. You have to document multiple hypoglycemia less than 50, have an A1C between 7 and 10, and have 4 weeks of logs. I want to scream every time. So we're working on that. We're sending letters. I think it comes down to the insurance though, with a lot of these patients.
And also too, we're revamping our education process. So we want to introduce technology across the board to everyone equally. And I don't think we do a great job of it right now. So in January, the plan is to meet and clinic-wide and kind of reestablish how we're going to educate our new onset patients. And we're hoping, Grace and I've already started working on like a technology handout slide, all the ways to like hit everyone equally the same way.
Yeah, I was gonna ask if you know, some of your families that may have just recently gone CGM.
Yeah. We're in the process of doing that because we're going to be redoing our education from like day one on. And so we're trying to like also angle to target those new onsets from the beginning. So we'll be talking with our families as they come in, like, how would you like to hear about this as day one?
For what you just said was the medication, what Ohio had similar.
Yes, we have the letter. We have the letter. It's been sent. Well, it's getting signed and it will be sent. Yeah. Mm. Yeah.
Together with data that you may have internally that A1Cs are better, but now we have public data to say that. And I think that's what came to these measures.
Okay, so you think I should add, and we want a meeting with you to this letter? Cool. Yes, of course. Yeah. Nana's been raising her hand like since the beginning.
This is like a question for. So I think, because we hear this a lot about insurance, that one of our CDM equity projects, part of it should be inequity across states based on insurance. So we know everybody's state insurance. We can look to see what their Medicare and Medicaid plans are, what the requirements are, and what the average A1C is by state.
Oh, that'd be
And if there's
good.
inequities across states, that's good. That Ohio has
Yeah.
open access to CDM and our A1Cs are 8. Arkansas doesn't give anybody.
Well, yeah, so Nana's saying to go to look at, see if I can repeat this, to look at what insurances cover across the states, what Medicaids cover, and what these states' A1Cs are. And I think, and I don't know if every state has this, so Tennessee has like 5 different Medicaids. I guess most places do. So I think we'd have to break it down by each kind, right? And look at. Yeah. And then we can use that to harass. Yeah, can we do that? I think that would be really great. Yeah, well, in this Ameri group, like you have to document less than 50. What am I gonna do? Go tell my patients to become hypoglycemic? Like, oh my
Yeah.
God, it kills me. Yeah. Oh, we were out of time.
So. So thanks to everybody. We'll continue this. I want to be respectful of the next presenter. So we have Kajal Gandhi coming from Nationwide Children's to talk about their CGM projects in youth with type 1.
You guys just took my whole presentation, so. I'm talking about all of it. Okay, how do I advance? So, hi, everybody. I'm Kajal Gandhi. I'm one of the pediatric endocrinology faculty here at in Ohio at Nationwide Children's Hospital, Ohio State. Dr. Camboj is my chief, and she's here for support, I think. So, or to correct me if I'm wrong. So, I wanted to introduce our project, and thank you for everyone for inviting us to speak about our project today and for everyone here to listen. It's continuing improvement of our health equity and use of CGM monitoring technology among our youth with type 1 diabetes at Nationwide Children's. We introduced a few members of our team. We have a huge QI group. We're very blessed about that. Dr. Brimba, Dr. Endike, Dr. Camboj, who's our site PI, and of course our wonderful, I think everybody knows who he is Don Buckingham, who makes us all look good. So we'll get started. So wanted to tell you that our project was a part of a project of a big institutional initiative for Journey to Best Outcomes through our Nationwide Children's Hospital Strategic Plan. So that acronym SCOPE at the bottom stands for Safety, Clinical Outcomes, Population Health, and Equity Experience. So we are one of quality improvement, robust quality improvement initiatives through the Center of Clinical Excellence that helped improve our diabetes technology access and utilization. And now through our equity and experience. Our institution is very supportive of quality improvement projects and was one of the innovators early on for quality improvement through our Zero Here program, and actually has an equity QI toolkit that helps us guide our initiatives. So I don't need to tell this whole audience about this, but the use of CGMs have been shown to improve glycemic control and improve quality of life. And multiple literature has shown disparities in the access to diabetes technology, the continued utilization of technology, and that racial and ethnic disparities have shown that can affect diabetes outcomes. So, sorry. So the Center for Clinical Excellence, our key quality initiative, was to increase pump and CGM equity ratio among our T1D patients who are Black and white to 1-to-1, meaning for every one white patient with type 1 diabetes that has a CGM or a pump, that there's one Black patient with type 1 diabetes with a pump or CGM. And so our baseline was 0.44 to 1 for the pump and for 0.7 to 1 for the CGM through this year and to continue through 2023 and beyond. So how did we do this? So we took our patient clinic census among our type 1 diabetes patient population for greater than 12 months, which is our initial initiative, and it was evaluated for 22 months. The 22 months was a combination of our timeline versus the T1D collaborative timeline as well. So that's why that timeline existed for 22 months. We are fortunate enough to have a diabetes clinic flow sheet that helps us track new CGM uptake. So the first time that a patient answers the question, do you use a CGM? In addition, we have that continued data to show that they're continuing to use that CGM utilization and document time in range and CGM data. Our CGM uptake ratio, which is what we calculated, was we used a process outcome. So for we didn't use individual patients. We went through a clinic flow and used for every 100 clinic visits, the number of Black T1D populations with CGM use through 100 clinic visits on a monthly basis over the white T1D population through 100 clinic visits, and of course, our goal ratio being 1-to-1. So I wanted to highlight not only our equity work, but also the work that we have done since 2016 to increase CGM utilization, as Dr. Camboj had mentioned. So I wanted to make a note and give a shout out to the T1D exchange, because this year, she's like cheering, right? Because when we joined Nationwide Children's joined the T1D exchange in 2016, this was our first project collaborating with the T1D exchange. So I wanted to tell all the new centers out there that you can be really successful with a lot of people's help, especially in the ones in this room. So as you can see, in 2016, we had a percentage of patients, you can't see the title, but utilizing CGM was ranging around 10% or below. And throughout, this is through July of 2022, we have over consistently 80% CGM utilization through our whole T1D patient population at Nationwide Children's. And I'm going to talk a little bit about this through our key driver diagrams, but I didn't put them on this graph, but some of the interventions that we did, and some of you had mentioned these in our discussions earlier, is one is that we did a fishbone diagram to figure out, because that's really important to know, where are your barriers for CGM utilization? And we talk about insurance, we talk about paperwork, we talk about all of these things, but honestly, where it starts is the provider. The provider has to discuss it with a family in order for anything else to happen, right? So because of that, we did some things that make it easier for the provider to help start the CGM. And so one of the things that we did was at this time, now we do direct pharmacy prescriptions of CGM, but back then we had to do letter of medical necessities, right? So we incorporated electronic integration of the letter of medical necessity into Epic that in the clinic flow that allowed these providers to, some of it was pre-populated. And so all we had to do was select a few things and sign it. And it was already sent to Dexcom, or at that time it was just Dexcom. But that actually improved a lot for our provider ease to introduce it. The second thing that we did, and we actually discussed, and Dr. Camboj eloquently introduced this, is that we petitioned the Ohio Department of Medicaid to ease the blood sugar requirements and those requirements to help integrate more patients with CGM. And that's all occurred through 2018, through 2017, through 2019. And as you can see that increase, right? The other thing that I think I was talking to Todd and some other people about is that we have to meet these patients where they are. We can't talk about CGM if they don't show up to clinic, or I can't talk about anything if they don't show up. So we also did family focus groups, and family focus groups outside of clinic. We had different topics, and one of them was diabetes technology, and we did that in I think it was 2021. And of course, COVID happened, everyone had that dip. And so now we're looking at this over time, and this is what introduced our work into equity. So we found that, well, we have a lot of increase in CGM utilization, but how do we reduce that disparity? Despite that increase in CGM utilization, we still had a disparity. So we took 9-month clinical aggregation, not unique patient count, as I mentioned before. And as you can see, through 100 people clinic visits, we had 61.8 in the general population. But as you can see, the Black and Hispanic population were under the mean as compared to the whites. Asian, we found that was higher, but we feel like that was probably just because of small patient numbers that probably other centers have seen as well. So that represented an opportunity for us to intervene, and that's where we started. So this is similar to some of the graphs that have been presented earlier. Is I know this is a busy slide, but the gray bars in the background are the total percentage of Black and white populations only. 5 minutes, okay. And as you can see over time with all our interventions, we have reduced a little bit of that disparity, although we still have more work to go. And so this is the percentage of Black and white that have CGM utilization. So our key driver diagrams just show some interventions that we talked about. Didn't include the overall global interventions that I mentioned earlier, just to increase CGM utilization in our population, but things specifically that we're doing with equity is, we address social determinants of health that a lot of programs are already doing. We revamped all our CGM education, and we want to provide translations for that. We have a CGM sample program that allows our patients now to have a CGM at diagnosis, which is really great. And we're also looking into bias, which I know that's an ongoing intervention with a lot of providers and centers with our patients, and with our providers. So as you can see, this is our equity ratio. So we had a baseline of 0.7 Black patients for every 1 patient using CGM. And so with our increase of global CGM utilization being increased, as well as some of our equity projects that were ongoing, we've increased that to 0.9. So we have a little bit of a shift change, still have a lot more work to go, and the equity project is still ongoing and new, but this is very encouraging. And we hope to continue this with our T1D collaborative folks and with all of you, and to give us great ideas on how to do this better. But I'd like to thank, I'm sorry, I'd like to thank Dr. Campos, our whole QI team, T1D Exchange, and all of you for patiently listening. Thanks. Oh, sure.
I have a question about what you heard from the focus group. Did anything help you to identify one particular intervention for non-Hispanic Black population?
Yeah, so that's a great question. Thank you for your compliment. So the question was, in our focus groups, what questions were raised that from our families that said, why aren't they using CGM? And that's a fantastic question. I wanted to note that in the family focus groups, we personally went as providers, but actually we introduced ourselves. We did a little bit of an informational thing. We actually left after a few, like 20 minutes, 20, 30 minutes, and we allowed our staff, like our diabetes educators or social workers, to sit with the families, because sometimes our own patients were in the room and they felt uncomfortable talking about things when we were there. So of course we were there for support information and all that medical knowledge, but then we left. And so what we found was they're just not bringing it up at the clinic visit. I don't feel comfortable talking to my provider about it, and I don't feel bringing it up, and they don't bring it up. The other thing was just time. We all talk about our diabetes clinic visits being way too short. And I think there was just a time limit in the, we had so much to talk about, we didn't have time. So on that first point, we're not talking about it. That's actually one of our equity initiatives, is that we've given out handouts to everybody in the clinic through our clinic flow who's not on a pump or a CGM, to say, hey, reminder, talk to your provider about a CGM and pump. And then of course it's the provider's discretion. Of course, they know the patient the best, but at least it brings up the topic and awareness. And then we also had, sorry, I'm almost done, I promise. One big thing was a provider aspect, right? So CGM is probably a no-brainer where, you know, of course, CGM is going to help diabetes care. The pumps was a little bit of a issue with our providers saying, I'm not putting that patient on a pump. But I think, so we had a long discussion about the standardization of who should be on a pump. Dr. Gamble knows, we had a long discussion about, oh, they should be using CGM, or they should have had diabetes education. They've been a patient for 12 months. And there was a lot of things floated around. But at the end of the day, we were like, we just want to bring awareness. Whether you decide they are on a pump or not, or a CGM or not, is your choice. So our only two criteria was they had a type 1 diabetes diagnosis and they completed basic diabetes education. That is it. And just to bring awareness, and we found that we are increasing amount of pump awareness and families that we want to pump. And we want to target, every clinic has this. 10% of our patients are like great and fantastic and they're ambassadors. 10% of our patients, or 20%, 10% are the strugglers and they have a lot of challenges. We're targeting that middle part where those people are not doing that well. I promise I'm done.
There's one question on that, right? Yes.
Hi. Hi.
One thing I'm going to do is fire off and understanding what coverage is. There's a site called diabetes.org, and there's a provider part of that site. There will be, there will be data from a database called Policy Reporter that will, I pull all information from commercial and public insurance and by state, by devices, to let you know what the coverage criteria are. So that will be available sometime in 2022. And then the other thing I just wanted to, and I'll be talking about this one tomorrow, is that we're doing something we're very focused on how we can do that down through Medicaid. There's so many standards. There's a report that the Center for Healthcare Strategy put out about a year ago now that we felt all coverage criteria to be for certain Medicaid. So something that we are looking into to understand across the care what policies are to hopefully do more concern. So I welcome discussion around that, but that is a report.
Thank you. I think we'll stop there, unfortunately, but I think we have lunch after, so we can continue this through lunch. Thank you. Okay, and our last but not least presenter is Mary Pat Keller from
different than the ones that came before. I'm going to be talking about the results of the type 1 diabetes exchange QI clinic practice survey from 2021. But one of the things that I think is consistent across the talks that we had today in this session is that some of the interventions require staffing, right? We need more people to help people use these tools. So we're going to go through what we found out. These are my abstract co-authors and their affiliations. And to start, I just wanted to look back as a background to the data that was collected by the Type 1 Diabetes Exchange, not the Type 1 Diabetes Exchange QI collaborative. So in 2015, the Type 1 Diabetes Exchange actually collected data, and it identified significant disparities between staffing in the pediatric clinics and the adult clinics. So you can see on the left-hand side, physician, nurse practitioner, diabetes educator, and registered dietitian. Then the mean ratio in the pediatrics versus the adult and the p-values. So the mean ratio of physicians, for instance, in pediatrics was 1 physician for 171 patients, a high standard deviation of 93, but then the ratio in adults was 1 physician for 218 patients. That was not statistically significant, but when you look at all of the others, they're very statistically significant. And while the data isn't shown here, it was striking that apparently only 42% of adult diabetes clinics had any behavioral health support, like even a social worker or a psychologist, compared to 87% of the pediatric clinics that were involved. And given all of the things we know that impact outcomes, social determinants of health, and all of these challenges, and this morning, Dave showed us the comorbidities. It struck me that the top 2 were depression and anxiety. So, so that was a major finding. And I think we know that as our pediatric patients go into the adult world, that sort of period is a high-risk period. And it's just something to keep in mind. So we wanted to do an update on the staffing and look at the diabetes clinics in the Type 1 Diabetes Exchange QI group, which is a different group, right? It's more real-world data across the country. And also see, is there still this disparity between adults and pediatric staffing in different disciplines? So we sent out the survey. Many of you may have completed it. They were collected between October 5th and November 19th of 2021. 34 sites responded, 25 of them pediatric and 9 adults. And we collected the full-time equivalents of different disciplines. Data were cleaned and analyzed in RStudio, and then we expressed the FTEs of different team members per 1,000 patients. And we compared the adult versus the pediatric sites using t-tests. And we also added additional support staff that we didn't traditionally look at. Who is on for evening and weekend call? Do you work with patient navigators? Do you work with community health workers? And so on. So here is the initial data in this table. So if you look on the left-hand side, again, you have which discipline. Physician is the first, then NPs and PAs, social workers, nurses, diabetes educators, and psychology. If you look all the way at the other end, what you can see is that they are all very statistically significantly different, so that the pediatrics clinics are staffed much more generously than the adult clinics. And I really drew our attention to the social worker, the nurse, and the diabetes educator, because they're shockingly different. And the social work in particular, you can see that for pediatric clinics, there's 0.9 social workers per 1,000 patients, and there is 0.09 per 1,000 patients in the adult clinics. So that's outrageous, right? With everything we know about what's needed to help people succeed with managing their type 1 diabetes. So here are some of the additional support staff that were in place. We looked at community health workers, patient navigators, parent partners, whether or not people were responsible for inpatient diabetes education, whether they had pharmacy partners on their team, diabetes specific medical assistance, and child life. Now, these are all yes, no, not a ratio. But what really you could see is most of them, with the exception of parent partners and child life, which makes sense, were not statistically different between the different between peds and adults. The one trend that is sort of interesting and goes along with some of the work that I'm hearing people talk about today that they're doing is that more adult centers work with community health workers and more pediatric centers have patient navigators. It's not statistically significant, just a little bit of a trend. In terms of the roles of managing diabetes patients on the weekend and evenings, the vast majority are following a traditional model where you have a fellow and an attending, and that was true for peds and adults. The one thing that was kind of interesting was that the nurse practitioner or physician assistant participation in on-call was only happening in 4 of the 33 centers, and all 4 of those were in pediatric centers. None of the adults reported having that. The next thing I did was, because I just thought it would be interesting, and I recognize these are different clinics, was to take a look at what we published in 2015 in those groups from the Type 1 Diabetes Exchange and see what the difference looked like compared to then. So as you can see, the 2015 staffing that I showed us in the first slide is here. And I put another column all the way on the right, and I just termed it disparity factor, meaning basically, if you look at the physician in 2015, the disparity, there was 78% of the FTE was available for adults as for pediatrics, right? For nurse practitioners, 54%. For diabetes educators, 36%, as much staffing for adults as in peds. So I thought, okay, let's look at the 2021 numbers, and they're alarming. They're alarming for a lot of reasons. One is that all of the ratios for pediatrics and adults have gotten much worse. Is that because this is real world data and these are different people that we're asking? I don't know. Is it a difference truly in staffing? So now there is one adult provider for 628 patients. One nurse practitioner for 1,478 patients. One diabetes educator for 1,250 patients. And the disparities, and well, so they're worse for pediatrics also, as you can see, 171 to 278 in terms of physicians, 347 to 667 for nurse practitioners, and 1 to 58 to 1 to 303 for diabetes educators. And so that's terrible too. But if you look at the disparity factor, it's also gotten worse consistently across the board. So still, even though I am concerned about the amount of disparity, it's worse for everyone. And so that's a major concern. I think that these are consistent essentially. What do I say? Keep break rooms open. All right. Good choice. So essentially, these are consistent, right? We're still seeing terrible disparities between the adult and the pediatric practices. And the inequities are particularly notable in behavioral health support. And our center is a pediatric diabetes center, and we're really fortunate to have an integrated behavioral health program. And I think with Ori and Osagi's blessing, I'm going to mention another project that we are interested in talking with people about, because that much of it is not reimbursable. So, and yet I feel that it's incredibly important, and not for just being able to see a social worker or see a psychologist or see a psychiatrist or see a neuropsychologist, but we have all those people available to us to counsel us about how we can help the patient. So it's not that I need you to see the child and adolescent psychiatrist, but I can go talk to them about you. So it's the non-billable time that they are spending in our clinic that actually makes it integrated and that actually, I think, improves their outcomes. So we have come up with the possibility that perhaps we could identify a type of outline for bundling payments. And we're working as a group with a group of people originally from the Pediatric Endocrine Society. This idea came up so that we could not have to, what feels like nickel and dime the patients for every screener. I didn't ask you to screen me for depression. Why am I paying $10, right? So, so that's something that we're going to be looking for partners to work together with us to try to see if we could do that for new onsets. And then for the post-intensive period, like what do the two packages look like so that it's not, oh, I don't want to see the diabetes educator today because I don't have coverage for that, which happens, right? And so you either see the diabetes educator and we don't bill, or they don't see the diabetes educator, which seems impossible. So what we don't have here and what we could potentially, hopefully gather in this next phase, in this bundling project, would be how these ratios of staffing affect outcomes. So we weren't able to look at that here, but we do want to look at that because that would be much more powerful evidence, obviously, that they should be paying for all of those things. And we want to study here through the type 1 diabetes exchange, separate from that, whether or not this impacts not just outcomes, but the successful transition of young adults, you know, which is Shivani's work, into the adult care setting. So the other findings were that there were no statistically significant differences between the type of weekend and nighttime coverage, and 16%, which is only 4 pediatric sites, but and 0 adult sites incorporated nurse practitioner coverage in their evening and weekend coverage, which might reflect an increased need for fellowship applicants in pediatric endocrinology. And that is my last slide. Oh, it doesn't want to move, but okay, thank you. My next slide says thank you. Mhm.
I don't know how we're going to include the endo fellow applicants. That's the problem. I also see that's been in for several years now, and now it's translating to availability of endo faculty.
Yeah.
And we're all going to struggle to the rate because I was going to work.
Yeah.
This year and years later.
Right.
Thirdly, I'm hearing a had a conversation with my group 3 days ago, and the support for NC coverage is an asking for the state of lack of fellow.
Right. Right. Us too. Yeah.
One, oh, that's not what they do. And 2, NC has much diverse opportunities to available to them.
Mm.
So, I have more overall endocrinology
Right. Right.
overnight.
Right. Thank you.
But what I think about on the phone and Have anyone looked at the diversity pool is for providers, staff, the clinic, and the provider. Because in kind of small communities, if we don't look at the survey, and then can't relate, what's that goes down and the up.
That is on our agenda to do, because absolutely, I agree. Oh, the question, have we looked at the diversity in terms of providers, whether it be the physicians, nurse practitioners, nurses, social workers, and clearly that plays a role. It has to, and it doesn't match. I'm quite certain in our center, it doesn't match. And I think that that has to be something we focus on and acknowledge. And so I've been asking to work with community health workers so that we could pull people from different communities and work with them, but still not, they're not the doctor. But it's an important point to keep in mind and to consider. Thank you.
Multiple children kind of fund towards with scholarships, people to do like weather patients and things like everything in my life. They're fine, but it's definitely, I think it's a human being how I have that, you know, this is what it currently looks like, so that those actual people that you know, people going because it's not into all, I think it's job, right? I don't know if this is just my inner blood, but in the interview list that we, for our side, there, first time it's happened for us, we have 2 international students that have implemented our site, so coming through now, it's so applicants. And that was a big uptick for us, and we have international students, but it felt like, you know, my inner blood, and we're kind of, we were able to keep them in whether they stay as a fellow or not, but like they're at least out there, they want to do it, and they had a good experience. So, you know, if we can't recruit,
I just would like to wrap up, but I hope the discussion continues at lunch. I think we could talk about this all day. I would love that. I really would. I'd like to thank our speakers and everyone for attending. It really was a pleasure to hear everybody's thoughts and presentations. Thank you so much.